Hello and good day to my module supervisors and everyone watching. I'm Shivashni Silvanathan, a first semester student of the MSc Molecular Medicine and Genomic Medicine. The title of my presentation today is Lung Cancer, Epidemiology, Molecular and Cellular Pathways, Therapeutic Insights and Future Research Prospects. This will be the flow of my presentation today. I will start with a general and brief introduction of lung cancer. Lung cancer is the single most deadly and most common cancer affecting the global population, according to the Global Cancer Observatory report. This is a report by the International Agency for Research on Cancer, a team dedicated to only cancer research by WHO. The classification of lung cancer was traditionally divided into only two main categories: non-small cell lung cancer or small cell lung cancer. These are histological classifications with further subtypes. However, with deeper understanding of the disease over the years, lung cancer can further be classified according to its molecular pathology like EGFR or ALK mutation and according to its immune checkpoint pathway like PD-L1 expression level. In a broad sense, these are the major differences between the histological types of lung cancer. Non-small cell lung cancer makes up 85% of all lung cancer, and it includes subtypes such as adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. This type of cancer has a relatively slower growth compared to small cell lung carcinoma, and adenocarcinoma is the most common subtype, especially occurring in non-smokers. Squamous cell carcinoma is more prevalent in smokers. Molecular studies have identified key mutations in non-small cell lung cancer, including alterations in EGFR, KRAS, and ALK, which have driven the development of targeted therapies. On the other hand, small cell lung cancer is a highly aggressive form of lung cancer, making up 15% of all cases, and is associated with heavy smoking and rapid growth. Despite initially responding to chemo and radiation, patients with small cell lung cancer often have recurrent disease, leading to poor long-term survival outcomes. Moving on to the epidemiology of lung cancer. The magnitude of this disease, especially in Asia, can be seen in these graphics. The incidence of lung cancer in Asia makes up more than half, 63.1% of the total cases globally. 62.9% of total lung cancer deaths globally is attributed to Asian lung cancer deaths. Tobacco smoking could be a probable reason because it's very prevalent in Asian countries. Tobacco smoking is a major risk factor where smokers have a 15 to 30-fold higher risk of developing lung cancer compared to non-smokers. The 25% of lung cancer which occurs in non-smokers usually occur in women and in individuals in East Asia, possibly due to indoor air pollution, secondhand smoke, and genetic predisposition. Regionally in Malaysia, according to the latest Malaysia National Cancer Registry Report 2017 to 2021, lung cancer is the third most common cancer. And unfortunately, the percentage of lung cancer diagnosed at advanced stages, which is stage 3 and 4, increased to a very high 95.4%. The 5-year survival rate of lung cancer is also only 9%, which is below the global rate of 28%. Now moving on to the complex section of lung cancer, the molecular and cellular pathways. Due to constraints of time, my presentation will only focus on a particular pathway relevant to my proposed research idea later in the presentation. Now these are the famous hallmarks of cancer by Hanahan and Weinberg. This list has been updated in year 2022 since its inception in year 2000. To start off, just like other malignancies, the development of lung cancer from normal pulmonary epithelium is a multi-step process. As we know, multiple environmental and occupational carcinogens has been identified which can trigger gene alteration in cells, leading to neoplasms or abnormal growth. But what gives these neoplasms its malignant features compared to its benign counterpart? And what are the characteristics that these mutations or DNA damage give the affected cells that make them malignant or cancerous in the first place? These questions are answered by these hallmarks of cancer. In lung cancer, a number of aberrations underlie tumor development and progression, including oncogenic alterations like mutations and tumor-suppressing alterations like deletions, etc. Epigenetic changes, telomerase alterations, and microRNA modifications also underlie tumor development and progression. My presentation will focus on oncogenic alteration, particularly EGFR mutation. Now, epidermal growth factor receptor or EGFR belongs to a four-member family of transmembrane receptor tyrosine kinases. EGFR is expressed by normal pulmonary epithelium and also other normal epithelial cells such as skin and the GI tract. This distribution underlies the common toxicities of EGFR inhibitors, where patients usually have side effects like diarrhea and rash. The problem occurs when there's an increased EGFR protein expression or EGFR gene amplification, mutation, or rearrangement. This has been demonstrated in multiple malignancies and is a major pathway for tumor development. In non-small cell lung cancer, EGFR mutations are usually centered around exon 18 to 21, commonly in exon 19 and exon 21. This molecular alteration hyperactivates the EGFR tyrosine kinase, rendering cancer cells highly dependent on the EGFR oncogenic pathway for survival. This phenomena is known as the oncogene addiction, and this is what makes them highly sensitive to EGFR inhibitor drugs. 40% of Malaysian non-small cell lung cancer patients harbor the EGFR mutation. Now this figure here illustrates the EGFR activation, inhibition, and signaling. EGFR has an extracellular ligand binding domain, a transmembrane anchoring region, and an intracellular tyrosine kinase. After binding of the ligand, which are growth factor proteins, receptor subunits dimerize, resulting in autophosphorylation of intracellular tyrosine residues. This action creates docking sites for numerous intracellular effector proteins, thereby generating multiple signal transduction cascades. This includes the RAS-RAF-MEK pathway and other pathways. These molecular signals ultimately result in sustained cellular proliferation, resistance to apoptosis, cellular invasion, metastasis, and angiogenesis, which are all, again, familiar hallmarks of cancer. We move on to the clinically important section, treatment insights. So the conventional treatments of lung cancer involve the usual cytotoxic agents like chemotherapy and also radiotherapy. These treatments are considerably effective, but they lack the specificity against the target molecular aberrations, and they have poor bioavailability. On top of that, the side effect profiles of cytotoxic chemotherapy is also more systemic in nature, making it intolerable and not suitable for many patients. However, over the last 2 decades, with the advent of precision medicine, two new treatments have come into the picture, which is number one, targeted therapy, and number two, immunotherapy. This has improved the lung cancer treatment landscape dramatically. Targeted therapy has a major influence by directly targeting molecular abnormalities of cancer cells. This figure shows the target genes involved and the drugs which inhibit these particular genes. Immune checkpoint inhibitors also play a role in precision medicine of lung cancer. Immune checkpoints like PD-1 and PD-L1 and also CTLA-4, they usually block the T-cell activation in the tumor microenvironment, allowing cancer cells to avoid being detected by the immune system. However, immune checkpoint inhibitors like PD-1 inhibitor like pembrolizumab and PD-L1 inhibitors like durvalumab, they disrupt this interaction, allowing T cells to be activated and mount an immune attack against tumor cell, leading to cell death. My focus today will be on targeted therapy. This figure shows molecular targets of potential treatment based on the particular hallmarks of cancer which the targeted drugs can inhibit. I'll be focusing again on what is famously known as the superstars of targeted treatment, the EGFR inhibitors, particularly EGFR tyrosine kinase inhibitors. They were discovered and introduced to inactivate EGFR mutation and also improve patient progression-free survival and prognosis. Unfortunately, over time, resistant mechanism towards the older generation TKI, like the first generation gefitinib, second generation erlotinib, developed due to new mutations like the T790M mutation. This was evident in Malaysia as well. A recent 2024 study showed that 69% of lung cancer patients in Malaysia developed the T790M mutation. So on to the final part of my presentation, research gap and potential research prospect in lung cancer. The research gap which I have put forward in my presentation is on acquired resistance in TKI treatment. Now, targeted treatment, particularly TKI, has dramatically improved outcomes of EGFR mutated non-small cell lung cancer patients for over 2 decades. Even though resistance mechanisms in this group of patients, which cause the drugs incapable of controlling the disease and threaten its efficacy, are being widely studied, strategies like combination therapies to overcome or delay this resistance are still lacking in the real-world settings. This is a clinically important scope of research as these resistance mechanisms will leave patients with minimal or no treatment options once acquired, leading to poor disease outcome. This brings us to my research proposal idea to bridge this gap. A phase 1 and 2 study of osimertinib in combination with the PROTAC-based EGFR degrader in patients with EGFR C797X mutated non-small cell lung cancer. A little background on this proposed research topic. Majority of patients treated with first or second generation TKI developed the T790M mutation, rendering those TKI ineffective, like I mentioned. Now, osimertinib, a third generation TKI, was designed to target this mutation and overcome the resistance, and since then it has been used effectively as the first-line treatment in this group of patients. However, this milestone was short-lived with the emergence of resistance in patients on osimertinib. Various mechanisms have been found in osimertinib resistance, but the most common was the EGFR C797X mutation. Combination therapies to address this resistance is shown in this figure, and it has been studied in various trials. However, none have advanced beyond the phase 3 clinical studies and are not yet available due to multiple factors like efficacy and safety profile. This is where PROTAC-based EGFR degrader enter the picture. PROTAC, or proteolysis targeting chimerase-based EGFR degrader, is one of the most recent and promising tools that degrade mutant EGFR proteins rather than inhibiting their activity, bypassing resistance mutations like C797X. Proteins are heterobifunctional small molecules composed of a ligand that binds to the target protein and can artificially induce degradation of the given protein of interest by hijacking the UPS system. My proposed study aims to explore the combination of osimertinib with the PROTAC-based EGFR degrader like the HJM561, a potent, selective, and orally bioavailable drug in patients with EGFR C797X mutated non-small cell lung cancer. This drug had showed robust antitumor activity and favorable safety profile in both cell line and patient-derived xenografts. This combination has only been tested in preclinical studies and at the time of this report has not entered clinical trials. But since oral administration of this drug showed robust antitumor activity in models that were resistant to osimertinib, that results suggest that HJM561 is a promising therapeutic option for overcoming EGFR triple mutated mediated drug resistance in non-small cell lung cancer patients. These are my references, and that is all for my presentation today. Thank you so much for all your time and feedback.